All right. Hello, everyone, and good afternoon. We are so excited to kick off today's program, which will focus on DCD heart recoveries and the two methodologies our presenting surgeons have employed in an effort to offer more life-saving transplants. My name is Deanna Fenton, Program Manager here at the Alliance, and as always, it's my pleasure to welcome you all here today. I'm sure you're all very eager for us to go ahead and get started, but before we do, I'd like to just take the next few minutes highlighting some key reminders. Now, for those of you who may be joining us for the very first time, we ask that you take note of the Q&A feature located in the Zoom navigation bar at the very bottom of your screen. All of your questions for our presenters should be submitted here. For those of you who submitted questions during the registration process, please know that we've done our best to compile your questions and we'll have our speakers address them throughout the course of the presentation. Should you have any additional questions, please feel free to submit them in the Q&A box. Once the presentation has concluded, we'll go ahead and transition to our Q&A discussion where our presenters will address as many of your questions as time allows. Now, additionally, for those of you joining us as a group, we ask that you take note of this poll. I'm going to go ahead and launch this here. For those of you who are taking advantage of this opportunity as a group learning opportunity, we ask that you complete this poll to indicate approximately how many people have joined your group. The results will help us and our presenters gauge the level of participation and engagement in today's program. That said, your assistance is greatly appreciated. Now, for anyone interested in our upcoming programs, please note that registration is currently open for our upcoming donation-focused webinar, which will focus on DCD in the pediatric population, while also exploring strategies to expand the donor pool. You're welcome to join us for that on March 9th at 2 p.m. Eastern. As for our next transplant-focused webinar, we're excited to share that registration is open for this program, which will focus on transplantation from the nutrition perspective, highlighting nutrition-focused patient exams. You can tune in for that on March 25th at 3 p.m. Eastern. As always, to stay up to date on all of our upcoming programs, please visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you are all eligible to claim continuing education credits. For this webinar, we are offering 1 CEP-C credit and 1 nursing contact hour for your participation. Additionally, there is a certificate of attendance that's available for those of you who may be seeking CEs that are not being offered. Prior to receiving your credits and certificates, you will be asked to complete a brief online evaluation that will give you the opportunity to provide us with your valuable feedback. If you're listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, without further ado, I'd like to go ahead and introduce our moderator for today's program, Sarah Duggins, Transplant Education Coordinator at UNC Health. Sarah, welcome, and thank you for joining us. At this point, I'll go ahead and turn it over to you to introduce both of our presenters.
Thank you, Deanna. Thank you for joining us today for what I hope is a very interesting webinar where we can learn a lot from both Dr. Schroeder and Dr. Kahn. Dr. Jacob Schroeder completed his cardiothoracic surgical residencies at Duke University Medical Center in Durham, North Carolina. He is now the surgical director of their heart transplant program and the co-director of their cardiothoracic surgery ICU. He is the principal site investigator for their Transmedic sponsored clinical trial evaluating the portable oxygen care system, heart for resuscitation, preservation, and assessment of hearts from donors after circulatory death. In the December of 2019, they were actually the first transplant program in the US to successfully perform a DCD heart transplant using that Transmedics device. We also have Dr. Zachary with us today, who completed his cardiothoracic surgical training at University of Maryland Medical Center, and then completed a fellowship in lung transplantation at Toronto General Hospital. He had spent the last 3 years at NYU Langone, where he was the primary investigator in their clinical trial entitled Heart Transplantation Using Normothermic Regional Perfusion Donation After Circulatory Death. But in January of this year, he did move upstate slightly to Northwell Health, where he is now the surgical director of both their advanced heart failure and cardiac transplantation and advanced lung failure and lung transplantation programs. So Dr. Schroeder will lead us off today with his half of the presentation, followed by Dr. Zachary Kahn. And like Deanna said, just put your questions in the Q&A at the bottom, and we will circle back to those at the end. Thank you.
Okay, can you guys hear me now?
We can, yes.
Okay, good. Sorry, can you rewind for me for a second? There we go. Okay, sorry about that. My name is Jacob Schroeder. As said, thanks so much for the introduction. I'm going to talk about our experience here at Duke with warm ex vivo perfusion. It has been a tremendous experience for the center and for our patients, really. For any future questions by anybody at any time, 24/7, feel free to call me or Chet Patel, who's our medical director, and Sarah Castellanova, who's our CRC, who actually really is sort of the brains of the outfit. A little bit about us. So, we're located in Durham, North Carolina, which is not, not the largest metropolitan area in the country, but as you see, our heart transplant volumes have continued to rise. Last year, we did 104 heart transplants. If you combine our number of heart transplants, lung transplants, LVADs, we're the largest thoracic organ program in the world. Heart transplantation, it's always been said, like a lot of transplantation, that it's a supply issue. The number of heart transplants remained relatively stable for decades, really at about, sort of 2,500. Now, over the last couple of years in this country, it's gone up mainly because of the opiate epidemic, but only a third of the hearts offered are utilized for heart transplant. And prior to December of 2019, none of the hearts that of DCD donors were utilized. As you know, DCD means donation after circulatory death, as opposed to brain dead patients. So, when I talk to patients about this trial, I talk about brain injured but not brain dead, so that people understand what we're talking about. These are all Maastricht category 3 patients who have had this devastating neurologic injury and we anticipate circulatory arrest. I gave a talk in 2016, maybe 2015 to Grand Rounds, and we had one of our ethicists there who's sort of a preeminent ethicist in the country. And we discussed this, both DCD donation, both the heart. We discussed both methods, both direct to perfusion, which I'm going to talk about, and normothermic regional perfusion, which Zach is going to talk about. And really, there should be no question about the ethical viability of this. This is not a question. Once you're determined to be dead in this country, you are dead, and neither of these methods violate that principle. And I think that's really important. That this is, we can continue to ask if it's an ethical question, but that question was answered many, many, many years ago. So why is this important? Well, as I said, classically, this has been a supply limited issue in terms of not having enough donors for all the recipients we have. Oliver Jowitz, one of our residents, a couple of years ago did a study where he looked back at all the DCD donors from 2005 to 2016. He segregated out the patients, the donors that were too young or too old, who had valve disease or low EF, et cetera. And just by looking at that, it showed that the donor population could be increased by at least 30% in this country. Now, what I will say is, from our volumes, is that we're seeing an even greater increase in donors and transplantations. Of note, the first heart transplant ever done by Christian Barnard in 1967 was actually a DCD donor heart transplantation. The donor was a young woman who was struck by a car and had a devastating neurologic injury. The donor and recipient were co-localized in adjacent operating rooms, similar to what has been done up at NYU essentially. And following withdrawal of life support and a 5-minute wait, like we generally do, the donor was placed on cardiopulmonary bypass, and the transplant was undertaken. So why do we really know why this will work? Well, on July 14th of 2014, Kumud Duttal, who is pictured in the top left-hand corner, and his team at St. Vincent's in Sydney actually did the first DCD heart transplant, other than the first transplant ever done. I've spoken to Kumud about this, and you see in these panels, the heart after it was initially put on the TransMedics organ care system, and then after a couple of hours. And I got to tell you, The hearts that we use do not look like this. This is somewhat scary looking. And I've talked to Kumit about, sort of what it took to go through with this, sort of the courage of him and their team. And they have been leading in this area of heart transplant since 2014. So, St. Vincent's has published their research, but the leading center in the world is actually Papworth in Cambridge, England. And I'm going to show you a little bit of their data. And so their 1-year survival is the same as their brain dead donor cohort. They've increased their transplant activity by 47% over 4 years. And this is probably the most important part of their data. These are the 6 active centers in the United Kingdom. So in the United Kingdom, they have it regionalized, and there are only 6 centers in the UK that actually do heart transplant. And the black line is the most important one. So that's the number of people on their wait list. And you see in Birmingham, Glasgow, Harefield, Manchester, Newcastle, that number goes up. But you see at Papworth, when they started doing DCD heart transplant, the number of people on their wait list has really plummeted. And again, that is exactly what we've seen here, as opposed to having a list that sometimes has as many as 20 people who are actively, we could transplant at any moment. There was a point last year where we had actually 2 people that we could transplant that were actively listed. So the traditional procurement, the patient is pronounced brain dead. We fly somewhere, we inspect the donor heart, we cannulate the heart for antegrade flush, apply the cross clamp, and arrest the heart and put it on ice. But obviously the clock is ticking when we do it with this manner. Our acceptable sort of amount of ischemic time essentially is around 4 hours or so. Our average here at Duke has always been around 3.5, maybe a little bit longer hours. So we've been relatively aggressive. But if you look at this in terms of what it actually takes, the time it takes, so 25 minutes to take the heart out, and if you say just 25 minutes to the airport and an hour flight. So in our region, really southeast region, maybe up to New York, and then 30-minute drive from our airport to Duke, and then 75 minutes, a little bit of an exaggeration, but that's still 3 hours and 35 minutes. So you have to say, well, okay, a 60-minute flight is about as far as you can go. Now, that's not exactly true, but then, with the EXPAND trial and the DCD trial, Transmedics Organ Care System has really changed the way we do things, especially here at Duke. This now allows us to travel. Really, we would go anywhere in the United States at this point. We've been offered hearts in California. The only reason we haven't been to California yet with the organ care system is that it would require stopping for refueling, and we would have to change our pilots out. And that we haven't quite figured out how to do that or get over that hump. But, I've been to Puerto Rico 4 times. We've been as far west as Wyoming, all with successful transplants. So the US DCD trial using the organ care system is a master's category 3 DCD donors. The donor ages are aged 18 to 49. And we, in this trial, have sort of defined the warm ischemic time as the time from when the systolic blood pressure is 50 or less, or the peripheral arterial saturation is 70 or less. So it's not, we don't talk about time from withdrawal. We talk about this warm ischemic time definition to really determine when the heart is hypoperfused. Obviously, the donors, there are some exclusion criteria. They shouldn't have had prior cardiac surgery or known coronary artery disease, been in shock or had a myocardial infarction, or had an ejection fraction of less than 50% on their last echocardiogram, or significant valve disease. For the recipients, they must be a primary heart transplant candidate, alone, age 18 or greater, and have written consent. They cannot have had a prior solid organ or bone marrow transplant. They can't be on dialysis or require multi-organ transplant. And then obviously we have to be willing to randomize them. So the initial randomization of the trial was 3-to-1 in this trial to the DCD possible arm. So in the DCD possible arm, you could get either. So because obviously if you were in this trial and you randomized to DCD, but a normal standard of care brain dead donor came up for those recipients, we're not going to turn that down. So it was randomized 3-to-1 to the DCD possible arm because we assumed that the majority of the DCD possible arm would actually get standard of care transplants. Now, about 3 or 4 months into the trial, they actually changed it to 1-to-1 because what we've realized is there are a lot of really good DCD donors out there, and that we were doing a lot more DCD transplants in the trial than standard of care brain dead donors. To sort of further bring that fact home, the DCD possible arm closed about a month and a half or 2 months before we actually had enough control patients for a 1-to-1 match, meaning, again, there are a lot of great DCD donors out there for successful transplantation. So how do we do this? So communication is key here for these procurements. So, we usually have a call amongst the OPOs, sometimes the OR staff, and really the other procurement teams prior to leaving Durham. We try and arrive an hour earlier, although we've gotten more efficient and we really only need about 20 minutes to set ourselves up. And then when we get there, we huddle with the OPO, OR staff, and the other surgical teams. Communication has been really important to make sure everyone is on the same page, everyone's comfortable with what we're doing. This is really not rocket science, but I know that especially when we go to these smaller hospitals that people get nervous with OR and OPO staff who've never done this before, or it's their, they have little experience. So we try and communicate as much as possible and try and help people understand exactly what we're doing. We set up all our own stuff when we go, and I think all the teams in the trial sort of do this. We try and be as self-sufficient as possible in the operating room. So we have our own Mayo stand with all the instruments we need, all the sutures, the back table for instrumentation for the OCS. We have that all set up. And essentially, once we get there, we really need no one's help. We just have to get there. So typically, prior to withdrawal of support, heparin is given. Withdrawal of life support occurs. Then again, at that SAT of 70 or a blood pressure of 50, our clock starts for warm ischemic time. So theoretically, within the trial, the cross clamp should be applied and the heart should be perfused within 30 minutes of that time. Although one of the investigators from one of the other centers called me a few months into the trial and said, hey, we sort of lost track of time and our warm ischemic time was 41 minutes. And I said, well, how's the heart doing? He said, oh, it's doing great. I said, okay, don't worry about it. Just send an email. It'll be fine. And so I think that just points out that although we have this idea from some basic science research that warm ischemic time should be less than 30 minutes, we really don't know. And that there's a tremendous amount of research that will need to be done for us to better understand this process. Obviously, if the patient does not pass away in that time, then we abort. If not, we usually have a 5-minute grace period depending on the hospital and the OPO, and then we do the procurement. The heart procurement's a little bit different than a normal procurement in that we need blood to put in the OCS. We've actually done it with packed cells, and I know other centers have done it with packed cells. The Sydney group seems to think that the hearts aren't quite as good with packed cells. Again, we don't have any idea because the numbers are so small. But the first thing we do is, you do a skin incision, sternotomy, and the way it used to be done is that we would put this cannula or tube in the right atrium and draw off about 1 liter of blood. And you do that generally by gravity drainage. You may not be able to imagine this, but when the heart has stopped, and the heart's not pumping, the pressure within the right atrium is quite high, and so this, although it sounds relatively easy, actually sometimes can be a little bit hectic. And so, but we do that, and we've sort of decided on a different way of doing it. But then we just do a normal procurement. Once the blood is drawn, the procurement for all the teams is exactly the same as any other procurement. One of the big issues, and I know one of the questions is this idea of drawing blood. The abdominal surgeons are very concerned about longer warm ischemic times and the risk of ischemic cholangiopathy for the liver. And so what we realized is that we could actually do this a lot faster. So rather than putting the cannula in the right atrium and trying to get the blood drained and having the teams wait, we bring a cell saver or self-salvage canister. And We connect our suctions to that and draw the blood off actively with the Neptune suction, which, you know, the only time when we've done this method that we've had to wait, or the abdominal team has had to wait for us, was the last one that I did, I think about a week and a half ago. And that wasn't because the blood draw took time, but because the sternal saw blade broke. And we had to actually get a new blade on the saw. But this method actually takes about 30 seconds to get that liter of blood out. So I think the concerns of the liver surgeons about waiting should not be an issue using this method. Again, that's just another picture. And then it's just a normal explant. And I won't go through this, but this is a picture of the heart on the OCS. It's a miniaturized heart-lung machine, essentially. And, you know, basically the blood is perfused from the pump you see at the top on the left into the heart. It really can only go into the aortic root and through the coronaries. It circulates through the coronary circulation out the right side of the heart. There's a cannula in the pulmonary artery, which we connect, and we can monitor how much coronary blood flow there is. There are ports to draw labs, et cetera, at the bottom. Then we monitor the heart, and on the pump, we check some labs. We follow these lactates, which are supposed to, I won't go into all tremendous detail about that, but it's supposed to give us some sense about the metabolic activity and health of the heart, although having done this now 120 times, I'm not sure that's actually what we should be following. We get back to Duke and we do the heart transplant. The nice thing about the OCS is that it's not just great for DCD, but other both donors and recipients, not just far away. Again, we've been to Puerto Rico, but for cases like congenital heart surgery patients where the explant may take hours and reconstruction of the heart may take hours and hours, we've used this very successfully. I can remember early on in the EXPAND heart trial, I went and got a heart, and our congenitals, or one of our congenital surgeons and one of my partners, did an explant where I got back, and they had about 2 hours, and I got back and we waited 2.5 more hours for them to remove stents and reconstruct this and that. The patient did great, and the heart was fine just sitting on the pump. As Sarah said, in 2019 on December 1st, we did the first adult DCD heart transplant in North America. It was a tremendous amount of work by our team, but a successful endeavor. And this is our experience to date with the organ care system. In black is sort of our brain dead donors. And so again, we've done almost 70 brain dead donors using the OCS. To date, we've evaluated 64 DCD hearts in the trial and in the continued access protocol. So 16 of those hearts were not implanted. So 13 of the donors did not expire. So we've been relatively smart about the donors that we actually fly out to look at. 13 donors did not expire, so that's 20%. So we actually 80% of the hearts that we've looked at actually the donors have passed away, which I think is pretty good. One donor was aborted to sternal saw malfunction, where literally the saw stopped and would not work. Early on, we turned down 2 hearts on the OCS, and that was very, very early on. What we've realized is that if we pick the right donor and their warm ischemic time is okay, then there's really no reason to turn down the heart. And we haven't turned down a heart since, I think, the first 6 weeks of the trial. So to date, we've done 48 DCD heart transplants, 34 in the initial part of the trial. We've done 7 in the heart cap, or that should be 8, I guess. And then 6 compassionate use exceptions, 4 heart kidneys and 2 redo heart transplants, because again, as part of the trial, combined organ transplant and redo heart transplant cannot be entered into the trial. This is a table showing our first 30 or so donors. And what you'll notice is, one, the most important thing is that our average age of our donors was 26. And, you can do almost anything to a 26-year-old healthy heart and it's going to be fine. And really, as I tell people I talk to about the trial, anybody should want a 26-year-old heart. You also see that about 25% of our initial cohort required some mechanical circulatory support after the transplant. That's not uncommon. If you look at the Sydney group, they're very aggressive with post-transplant mechanical circulatory support. What I will say is that this actually has gone down significantly. We're probably more down less than 10% as we've gotten better at this and more comfortable with the whole process. And then our recipient ischemic time has been about 19 minutes. So this is part of a trial, so I'm not really supposed to talk about results, but everyone wants to know about the results. So early on, this is just our first initial cohort. So we had 100% 30-day survival and 94% 6-month survival. I'll tell you that we had 2 mortalities in the first 34, and they were totally unrelated to heart and graft function. They were both related to infections. Unfortunately, both those patients passed away with totally normal heart function. Again, about 20% or so rate of early mechanical circulatory support, but it's unlike the primary graft dysfunction we saw, especially the rash we saw about 5 years ago. So each and every one of the patients that we put on either ECMO or an RVET have been able to come off this support within 24 hours. Essentially, as one of my old partners, Monty Donishman, who's now down at Emory, says, the heart's just had a bad day, so give it a little break. We do that, and essentially every single patient we've done have been discharged with normal RV and LV function. We've actually been doing routine cardiac MRIs on the DCD heart transplants and a cohort of brain dead transplants, and there's been no difference. And there's been no difference in rates of rejection. A lot of questions, and you guys got to some of them. Just things to think about in the future. The ideal team for DCD procurement, it takes a dedicated team, and we are lucky enough that we have Ben Briner, one of my partners, and I go on all the procurements. We have not been sending an opioid preservationist, which has been fine for us because we're self-sufficient. We send 2 other people at this point because it's still part of a trial. We have a CRC and one of our perfusionists, and we have a perfusion group of 32 people here, and about 8 of them are take call for transmedics runs. The donor age currently as part of the trial is 18 to 50, but this needs to be expanded to pediatric, both donors and recipients. Coronary angiography and DCD. So they're donors that we would love to do other studies for. And traditionally, obviously we're not allowed to do things that will cause risk or, to the donors. But what I will say is that we have actually gotten cats on a couple DCD donors. I think we always have to remember that it's the donor and their family's wish to donate. And if we ask the family, every time we've ever asked for something, they have been willing to do it and take on that risk, which is, just more a part of the gift that they're giving. And then, so the catchment area, as I said, we're willing, if we can figure out the plane issue, we'll go to California and do this. I'm not sure, somebody asked about Alaska. I'm not sure if we can get to Alaska or not, but hopefully University of Wisconsin will be up and University of Washington will be up and running. 2 of our fellows are actually operating in there. And so they just need to get the cardiologists on board because they're both trained and are very functional and facile with this. And then other questions, do we have does each center who wants to do this have a team, or do we start having a provincial team or regional teams that do this? We would be happy to participate and do DCD procurements for other centers. Fundings, this is expensive. There's no doubt about that. The disposables for each transplant are about $60,000. What I will say is that we have not had a negative financial impact at all. We have increased our number of transplants significantly. And then obviously NRP is a big question, and I'm going to turn it over to Zach and let him talk. Thanks, everyone.
All right, thanks so much. Really fantastic talk. So always hard to follow something as extensive as that, and I'll try not to be redundant. As Sarah had talked about it in the beginning, I have moved to Northwell, but all of the work that I'm going to talk about was done while I was at NYU, and for that reason, to give appropriate credit to all the other folks that are involved in a big enterprise like this to get it off the ground and running. I'll refer to it as the NYU experience or NYU protocol. And I have some disclosures, none of them are relevant to this talk though. So again, without trying to be too redundant, Christian Bernard did the first transplant in 1967, which most of you will immediately know, but as we just learned, it was in fact a DCD heart that was transplanted. And it was in the 1960s, right around that time, where these ethical concerns around DCD procurement and donation became relevant, and the adoption of what John Robertson termed the dead donor rule started to be practiced. And the fundamental idea behind it is a procurement of the organ should not cause the death of that patient. And all procurement actions have to take place after a death of a patient and that has now become a donor. And this was more solidified in the Uniform Determination Act in the 1970s, which stated an individual has sustained either an irreversible cessation of circulatory and respiratory function, or two, an irreversible cessation of all functions of the brain, including the brainstem, is dead. A determination of death must be made in accordance with acceptable medical standards. And the idea here is there are two ways that a person can die. Both are acceptable for the purposes of donation. However, in practice, the vast majority of transplants were and still are from donors with a brain death determination. This has progressively changed, although still a much smaller proportion of total transplants, but DCD transplantation has significantly increased over the last 2 decades with a much more exponential growth in the last several years. In fact, in 2019, there were over 5,000 organs transplanted from DCD, and even a handful of hearts have been transplanted during that time period, but not to a meaningful amount until most recently with the advent of the Transmedics OCS system, and hopefully I'll be able to convince you additionally with the utilization of normothermic regional perfusion. Just comparing DBD to DCD trends over time, there was an increase, again, as was stated, probably just secondary to the increase in the opioid epidemic, but that is relatively plateaued in regards to brain dead donors. However, there continues to be an upswing in DCD donors, despite a relatively stable opioid pandemic that has allowed further and further encroachment by the thoracic organs into something that's been utilized for many, many years by the abdominal teams quite well. And I will not plagiarize and give credit to the Duke folks for having done this work, but in their paper, they estimate at least a 20 to 30% increase in the potential total volume of heart transplantation with utilization of DCD. So it's a pretty significant contribution that's entirely untapped in hearts. Many of you probably have read this article defining pediatric heart transplantation in Colorado. This, I think, was a good example of where clinical care outpaced logistics and ethical concerns. And while I think today these concerns have been answered, and I'm happy to discuss in more detail in the Q&A section, how we came to the conclusion that we were ethically justifiable and in fact obligated to pursue this donor cohort. I think this was done in a way that allowed a lot of public doubt and frankly probably set us back about 10 years in regards to DCD donations. So I bring this up mostly as a lesson from our past on how moving the needle on a technology or a service that we can provide to our patients should always have the foundation behind it before the clinical care starts. And I think, as Jacob said, this definitely is the case now with DCD heart donation. So the 3 strategies, and I'm not going to belabor the extracorporeal perfusion component, but there is direct procurement and transplantation, which was the case in the Colorado group, and it was the case with Christian Barnard in 1967, where recipient and donors are co-located in a very rapid explant of the heart after arrest takes place. There's direct procurement and extracorporeal perfusion, and then what I will focus on, which is normothermic regional perfusion, with or without extracorporeal perfusion. And I say that here to emphasize that I don't think these technologies are mutually exclusive in any way. And in fact, I think many times will end up being synergistic or complementary to one another in the future. So I think it's important to understand that these can work together and in fact likely will. Just shortly going through the strategy for direct procurement and transplantation, a rapid sternotomy, exposure of the heart, administration of cold cardioplegia, and then really standard cardiectomy and cold storage beyond that point. But because of the unknown injury to the heart and the concern for adding a long cold ischemic time on top of that warm ischemic injury, these have always required co-location of the donor recipient. So both from a practical and from likely a questionable outcome standpoint, this has never gained traction and likely never will in modern transplantation. In contrast, and I'm going to skip through much of this because it's been covered far more eloquently than I will in this one slide, direct procurement and extracorporeal perfusion, such as the Transmedics OCS platform, I think is a much better alternative, and most importantly, does not require co-location at all. And in fact, as you heard, thousands of miles can actually be covered because it extends that perceived ischemic limit for hearts, which is a really important thing when adding other unknowns, not to also add potential ischemic injury on the cold side that might muddy the waters. Sorry. So normothermic regional perfusion, fundamentally, the idea is to regionally perfuse the heart and other organs. And this is not a new idea. It's been done for the abdominal organs in Europe for many, many years. It's been done now for thoracic organs in the UK for several years. But the principle is to exclude cerebral perfusion and then allow perfusion of the organs of interest for preservation. And there are many ways to cannulate. There are many strategies on avoiding cerebral perfusion. This picture happens to be pre-cannulation via the femoral vessels before going on. But I will try and talk about how we did it, and certainly I can explain some of our selection of why we chose one thing versus the other towards the end. But the case, it proceeds just like any other DCD. So care is withdrawn, there's cardiac arrest, there's a standoff period, and then a formal declaration of death by circulatory criteria. And I think that's a really important distinction. We are not causing brain death and then taking a brain dead donor's organs. This patient is dead, and we are taking organs from a circulatory death patient. And the question is asked, well, then why ligate the head vessels in the first place? And the answer is not to create brain death, but to avoid changing the natural progression of brain death from a circulatory arrest. So we don't want to alter the status quo that would happen but for our intervention. So therefore, we allow the normal progression of brain death, but this patient has already died prior to any intervention we make. So after we ligate the head vessels, we perfuse and resuscitate the heart and all other organs via blood circulated using standard equipment. ECMO or cardiopulmonary bypass is an option here. We chose to use cardiopulmonary bypass because we find it's far more versatile and far less expensive. For cannulation strategies, again, there are many options. We chose right atrial drainage, ascending aortic return. We put an LV vent via the superior pulmonary vein or left atrial appendage. And then we reperfuse for set periods of time and then completely divorce ourselves from cardiopulmonary bypass and do serial in vivo assessments. And these, frankly, as you'll see, will be the single best assessment of a heart you'll ever make. In fact, they'll be better than even a brain dead donor because you'll have transesophageal echocardiography, you'll have a SWAN in place, or at least PA measurements, and you can even directly measure the LVEDP by measuring your LV vent pressure. So it really does give you a phenomenally accurate in vivo real life assessment of how this heart is going to perform, and if there's been any sustained injury from the warm ischemic period. And that's going to be important when we talk about how long we are willing to wait on these donors to expire before sending the potential donor back up to the ICU. At the end of the case, so usually we're just waiting on the abdominal team to do their part, but once that happens, we're already divorced from circulatory support. So the heart is beating and supporting the patient just like it normally would. And then we proceed very akin to what a standard procurement would be with cross-clamp, cardioplegic arrest, cardiectomy, and cold storage, or again, potentially extracorporeal perfusion in this case. And drawing off the blood after an NRP on bypass is really simple because you have a reservoir full of blood that doesn't add any additional time or consternation from the abdominal team. And these patients historically, in our experience, have always been co-located for several reasons. One, it was starting a new trial and making sure that we could do this well. We thought we could do it better at our institution than bringing this onto the road. But there's no fundamental reason that a distant recipient couldn't be serviced by this, because again, there's a real life assessment after the injury that then is really converted to a standard donation. So there's no reason in my mind to think a heart that has a 60% EF with normal hemodynamics and an LVDP of 4, who then has a standard cardioplegic arrest and cold storage, couldn't go at least a reasonable distance. I think this is only going to be augmented with the addition of extracorporeal perfusion techniques such as the Transmedic system. Sorry. There are some advantages that I think NRP holds over isolated extracorporeal perfusion, and this has to do with cardiac surgeons forgetting that there are other people that exist in the world, and in the world of transplant, we're actually the small fish. So it's hard for us to admit, but it really is the reality. So the major advantage in my mind to NRP is it actually perfuses all organs with oxygenated blood. So it potentially minimizes warm ischemic injury and allows for reperfusion and resuscitation of all organs, not just the heart. And along the same lines, it allows for correction of all metabolic abnormalities such as acid-base disturbances during perfusion, and that can be an active process by our perfusionists, adding pharmaceutical intervention, but also just by native organ function. So unlike an isolated machine that doesn't have a kidney attached to it and doesn't have a liver attached to it, these donors typically do have working kidneys and livers that can augment our efforts to correct all of these metabolic abnormalities and really have the most physiologic reperfusion of an organ to, again, hopefully mitigate that warm ischemic injury that may have taken place. The in situ evaluation, as I alluded to earlier, is under true normal physiologic conditions. So we come off bypass completely. The lungs are the reason the patient is oxygenated and ventilated. The heart is the reason the patient has a blood pressure. And then we can do a true assessment, including transesophageal echocardiography, pulmonary artery catheterization with invasive hemodynamics, as well as systemic blood pressure assessment. And we have not actually had to do this yet, although we've been set up to do it in cases where we could do an on-table angiogram if there's any concern for coronary disease. But as was alluded to earlier, families have been really, really willing to help get these organs transplanted. And I think maybe there's some selection bias for a family willing to donate a heart as a DCD. They're willing to have more things done to that family member, but we've not had an issue actually getting a pre-withdrawal angiogram on these folks. However, this still is an option for when that is either logistically not feasible or not the wishes of the family and donor. Cost also becomes a big issue, and the average cost for a bypass circuit is around $1,200. There's some additional costs just for perfusionist time and things like that, so I rounded up to $2,500 to $5,000 versus greater than $50,000 or even $60,000 for some of the extracorporeal perfusion. I'm not saying that's not worth it. And in fact, like I said, in a synergistic approach, I think it could still make a ton of sense. But off the cost certainly are much lower with an NRP approach than they are with an extracorporeal perfusion. And some of this can be debated back and forth because you are transferring a patient that will ultimately be a donor, but the way cost reporting works with Medicare, it ends up always being a boon for the transplant center to bring that potential donor over to our institution. Along the same lines of perhaps helping all the organs by perfusing them, I think NRP offers a unique opportunity to change what is often a frenzied and sometimes conflict heavy interaction with other teams, because everyone is trying to do the best for their patient and their organ, and their motivation sometimes are diametrically opposed to the other teams trying to do the same for their patient and their organ. So in these cases of NRP, there's only one team at the table when the patient arrests and is declared. And there's only one team until the patient is fully supported on bypass and being perfused and having normal function. And in fact, the heart team then scrubs out when the abdominal team scrubs in. So there's just quite a bit of more collegial effort to help each other successfully procure organs. And this is not to say it can't be done professionally without NRP. I just think it lends itself to taking away a lot of the stress and frenzy associated with standard DCD procurements. And then again, I think there's a potential for improved preservation of all organs, although I think the data on this is very early and needs to be significantly more augmented before you can make that as a conclusion. I'm going to skip through much of this because it's already been presented. This is the Australian experience. The only point I would make here is the relatively high rate of ECMO support in those transplanted, which fundamentally I actually don't have a problem with, because if you look at the actual outcomes at 1 year, they are pretty phenomenal. In fact, they're nominally better than brain dead donation. But I think it is something you have to be aware of, and you have to be willing to offer relatively early and freely in order to pursue this kind of approach to DCD. Similarly, the UK experience, I won't get into too much, but they had a hybrid approach. Again, kind of thinking of this in potential synergistic efforts where they did NRP in about half of their patients, and then subsequently put those patients on OCS and then transplanted. Of note, they did certainly have one patient where they went directly from NRP to cold storage in this study, and they subsequently have done many more with NRP alone without OCS. Similarly, the outcomes, as we saw earlier, were excellent in the DCD group, and they did have around 3 patients or 12% rate of ECMO utilization, which was lower with NRP than OCS rather than OCS direct to transplant. So this is the protocol that we put together. The difference, I think, between the European and Australian experiences, we're allowed to withdraw care in the OR. We actually will wait up to 180 minutes for these patients. And only at that point, if no arrest, would we return to the ICU for further palliative care. And the reason I think we're able to wait up to 180 minutes is twofold. One is there's an actual functional normal physiologic in vivo assessment after. So if the heart doesn't look good, it doesn't look good and you don't use it. There's no question you'll ever transplant a heart that you don't know the answer to whether it's good or bad. So whether it's 60 minutes or 180 minutes, frankly, doesn't matter. And then the second is speculation on my part, to be fair, but I happen to think if the heart is still beating, there's enough coronary perfusion, probably that there's not a massive amount of warm ischemic injury that can't be overcome with some reperfusion on bypass. And our experience hasn't tested that, unfortunately, as you'll see when I get to some of the numbers, because most donors end up dying in a relatively quick fashion. But I think we still would be willing to wait up to 180 minutes to see if those hearts are viable. And that will be something that we definitely will have to answer in the future. After circulatory arrest, we have an obligatory 5-minute no touch, as what our institution asks for. The declaration of death is then made, and only the cardiac team scrubs in at this point. Median sternotomy is performed. We're the only people at the table. The head vessels, again, are ligated. The patient is placed on cardiopulmonary bypass. We put a vent in, we make sure everything's secured, and then we scrub out. Simultaneous to the abdominal team scrubbing in, the TE probe is placed, the patient's reintubated. If there's not a swan is usually floated, although sometimes we will just put a catheter in the PA directly. And then we will allow reperfusion for 30 minutes and then come off bypass and do a formal evaluation. If the heart looks great, we actually will stay off bypass unless we need to for some other reason. And I'll get into that in a second when regards to pulmonary function. If, however, the heart does not look good, we'll go back on, wait another 30 minutes, reevaluate the heart, and we will sequentially do that for up to 180 minutes. If at that point the heart doesn't look good, we will turn it down. Now, I'll say we've never in practice ever gotten near that because every single heart we've evaluated has been accepted within that first 30-minute time period, which I think goes to or speaks to the notion that immediate reperfusion with blood is a really good way to mitigate warm ischemic injury. Once the heart is accepted after any of these 30-minute time periods, we start with the recipient, and then basically the time until procurement is just the time it takes for the abdominal team to be ready. And whenever they are ready, we'll proceed. Now, similarly to what we were saying before in regards to a really complex recipient, you can extend this as long as you really need to before you cross clamp. And if you need an extra hour or two to dig out a really complex case, there's no downside to just waiting to cross clamp. But then procurement, again, is similar to a standard procurement because the patient has been divorced from cardiopulmonary bypass, a cross clamp is placed on the aorta, and a cardioplegic arrest and then cold preservation as per the norm is performed. And then the organ is brought currently co-located to an OR next door or to a distant OR potentially in the future. This should be 2020, but in January of 2020, we did our first NRP, which was the first in the United States. Through March, we then did 3 additional. However, COVID certainly put a stop to all of our transplant efforts, but particularly clinical trials, of which this was supposed to be 10 patients. In June of 2020, we were able to start transplanting again, and we proceeded to do our first heart-lung transplant via NRP DCD. And this went to a status 5 patient who was never, ever going to, I think, get transplanted otherwise. So I think this was a really beneficial approach to get her transplanted. She had a rough course, admittedly, but I think, again, otherwise she just would have sat on the list till she got quite a bit sicker. And today we've now performed 8 transplants via NRP DCD protocol. This is just a quick video to show you what the hemodynamic monitoring looks like. So obviously there's CVP, there's PA pressures, arterial pressures, EKG, and simultaneously there's a transesophageal echocardiogram being performed to evaluate how good or bad this heart is. Our donors were, I think, maybe a little bit older, but again, relatively conservative for being our first experience utilizing these hearts. So some of them were in their 20s, but most of them were in their 40s. Our age limit technically is 65, although I don't think we will be using anyone in that upper echelon of donors. Many of them were overdoses. Our first donor was quite interesting because it was a cirrhotic patient in renal failure dying of liver cirrhosis who was a heart-only donor. So it ended up being the only organ utilized from that DCD was the heart, which made it really easy to get the first one under our belt without any other team being worried about how it's going to work. But I have to say every donor after that, we at least gave liver and kidneys or lungs and kidneys And we never had a single issue with the other team being upset or trying to rush the process or frankly being anything but collaborative and collegial. So I think that's been a really good testament to the ability to control how these cases go. This fifth donor was that heart-lung donor, which we'll talk a little bit more about in just a second here. These are some of the times for these donors. Obviously, withdrawal diagonal phase was pretty fast. I think it's just the nature of good selection for potential donors, as was alluded to earlier. The time to asystole was also relatively quick in all of these donors. I think the longest was here 29 minutes. And then withdrawal to incision was also a very reasonable amount of time, which obviously includes the 5-minute no touch. The longest period of bypass was in our last two and in the heart lung. And that's because we actually went back on for either lung evaluation in this case or because the patient was profoundly hypoxic because of pneumonitis. So in these cases, we did go back on bypass for a longer period of time. However, the heart had been accepted after that first 30-minute assessment in every case that we've done so far. And what's equally interesting is the time it takes to actually start having sinus rhythm in these patients. And it was universally within a minute. Once or twice, I think we had a patient whose initial rhythm was a fibrillatory rhythm that we shocked once and then returned to a sinus rhythm. So I think that's, again, a very promising sign that these hearts are going to do well despite any amount of warm ischemic injury that they suffered, although the caveat being these are relatively short periods of time. And then the cold ischemic time after we cross-clamped and took the heart out was around 60 to 80 minutes for most patients. These are just the averages of the table I just showed you. But again, withdrawal to incision was usually around 20 to 25 minutes. And then incision to full bypass was around 11 minutes in most patients. So a pretty reasonable amount of time to get these patients on, with a functional warm ischemic time of around 32 minutes. And again, total bypass time around 60 minutes. For our recipients, everyone did exceptionally well. Even this one patient that did utilize VA ECMO, that was not for cardiac support. Biventricular function was phenomenal coming off, and actually we were on pretty minimal inotropes, but the patient developed pretty rapid PGD of the lungs. So I elected to leave the patient on central VA ECMO to decompress them and allow them to recover over the subsequent 2 to 3 days, after which we decannulated the patient with normal biventricular function and pulmonary function. The length of stay for most of these patients was less than 2 weeks, with the exception of that one patient that we had left on central VA for lung PGD. And the first biopsies were kind of as expected. No noticeable difference, albeit in a very small cohort of patients. And the 30-day mortality, to date mortality, is 0 in the entire cohort. I'll just quickly try and finish with this slide, which just gives you a good idea of how long we're perfusing these organs. And this happens to be the heart we're talking about here. But again, this is actually perfusion of all the organs, so the liver, the kidneys, the pancreas, the lungs. So active perfusion in most of these patients, again, was in that 30 to 40-minute time period. But then there was continued passive perfusion with a normal saturation and normal mean arterial pressure on minimal drips for an extended period beyond that. So the total reperfusion time of all of these organs was almost 2 hours in every case. And I think that lends itself to significant mitigation of potential warm ischemic injury. So in summary, DCD heart donation is possible, and I think has the potential to really increase the available hearts for transplantation, which is a significant need. The NRP model is the only methodology that preserves all organs, but I don't think in any way is mutually exclusive to other strategies for DCD utilization. And I think further data is really needed to know if we can, in fact, then have an additional cold ischemic time without extracorporeal perfusion, which we did not yet answer and probably will not in the confines of this initial 10-patient array, but in subsequent trials we plan to. And then systems need to be developed to expand our experience nationwide, and we're actively working with multiple other centers and create a consortium to try and regionalize these efforts to specialized centers around the country. And with that, I think we'll take questions.
All right, thank you, Dr. Khan, and thank you, Dr. Schroeder, both such fantastic presentations. I see we have a couple questions here in the Q&A, so I do want to make sure we have some time to address all of your questions, but I do also realize that we are approaching the top of the hour, so as long as Dr. Khan and Dr. Schroeder are both agreeable to staying on for a few additional minutes, we'll go ahead and address some of those questions. I see the thumbs up, so we'll go ahead and move on to a Q&A. So for those of you who have not yet submitted any questions, if you do have any questions that you'd like our presenters to address, please be sure to go ahead and submit them in the Q&A box. And with that, I'll go ahead and turn it back to Sarah. Thank you.
Hey, thank you. So thank you to Dr. Schroeder, who's popped in and helped answer a couple of questions in the Q&A box down there. We do have one question. I know Dr. Schroeder addressed ethics previously, but this question says, the primary donors seem to be opioid overdose donors, which seems to take advantage of a socially marginalized group. Do we feel like this is ethically appropriate? And I'll just add my piece on, or does this just represent our donor population in general?
I think you're absolutely right. It represents the donor population. And I think we just have to remember that, you know, it's the donor, it's that patient and their family's wishes to donate organs. And so it's not like we're not in China where they're forcing people to donate, honestly. And so it is unfortunate that a large portion or an increasing portion of people have been donors due to opiate overdoses, but we're still respecting their wishes to give that gift of life. I'm not sure if Zach has anything else to add to that.
No, I would just agree completely with the sentiment. At the end of the day, this is someone who is going to die, not of any effort we are pursuing. Their plan is to withdraw care on that loved one per their wishes. And that donor wants to try and have some good come from this horrible situation. So I really don't think it's a question of taking advantage of a socially marginalized group. I think the exact opposite. It's allowing a group that otherwise would not be able to pursue a very noble and valiant final act in this world. We are now allowing them to offer that to them. And I think it's a kindness in many ways, frankly.
Great, thank you. Someone else wants to know what other centers are offering DCD hearts right now?
So there's a handful of centers that are currently offering NRP. I only know of 2 other centers that have currently done an NRP, but there's 6 that I know of that are actively pursuing hospital approval or IRB approval, or both. So that would be about 9 for NRP. And I think Jacob can speak to how many are in the Transmedics trial.
Yeah, you know, we actually are also working on an NRP protocol, which unfortunately at Duke, that it's not easy to do anything. Unfortunately, we just can't seem to make this happen, despite multiple other centers doing. You know, Vanderbilt is actually flying out and doing NRP to ICE, which I think is interesting, and we'll see what their results are. But they've probably done over 10, I bet now. Within the trial, I mean, I don't actually even know how many there are, but it's over 10 centers from Florida, Georgia, San Diego, out in California, all the way up to the Northeast. So there are a number of, obviously their centers are interested in getting involved, which is smart. And one of the questions that I think were emailed in is, how do we get this out to other centers? I think we have to show that it's successful. I don't think and there's no question in my mind, I'm sure in Zach's, both methods are going to be successful. Other centers around the world have already shown this. And so it is our job as a community to make this happen for our patients, and not only for the recipients, but for the donors who want to donate their organs.
Yeah, and do you want me to answer this other question about ligation of the head vessels?
Yeah, go for it.
If you'd like.
Sure. So it is absolutely not to decrease suffering or to induce any kind of change. In fact, it's very much the opposite. The fundamental purpose of clamping the cerebral vessels or arch vessels of the aorta are to not change the natural progression when someone dies of a circulatory arrest. So after circulatory arrest, there is no flow to the brain and the brain will die at its normal pace. So we didn't want to change that event by recirculating blood to the brain. But that patient has already died, and the efforts we are doing is to maintain that death and normal progression that the body would otherwise, and the patient would otherwise undergo if we had not intervened. I hope that answers your question.
I think so. Doesn't look like we have any other questions coming in, and you guys did a great job of addressing a lot of the questions that were sent in prior to today's webinar. So, Deanna, I think you might be good.
Well, thank you, Sarah. Well, that said, I'll go ahead and conclude today's program. So on behalf of the Alliance, I'd like to once again thank Dr. Khan and Dr. Schroeder for such a comprehensive and informative presentation. And of course, to Sarah, we thank you for joining us and helping us to facilitate today's discussion. So thank you all for your involvement. And to our participants, we thank you, of course, for joining us, and we look forward to seeing you in the future. Enjoy the rest of your day, everyone.
Thanks, everyone.
Thank you so much. Have a good day.